Okay, sorry for the delay. I'm running a bit late this morning. So you can see we're about a month behind, unfortunately. Right, with everything that happened over the last month, COVID, protest, trauma, you name it. How was last night? Because that Saturday was terrible. It's okay. Manager. Yeah, Saturday I heard was really, really bad. Okay. So anyway, let's have a look at our ECG just to see what's going on. Right. So we're gonna, as usual, we always start off with this. So we know we're gonna analyze the axis, then the rhythm, P waves, PR interval, QRSs, and then regular groupings. Then we'll analyze the rate, then we'll analyze each zone. Then we'll try and figure out what's going on. All right. Okay, so let's have a look at this. So 51-year-old woman with persistent vomiting and severe lightheadedness after attending a picnic. Okay, let me just hide this 1 second. Right. So persistent nausea, vomiting, and severe lightheadedness. Right. So we can assume maybe the BPs are a bit low and things like that. This thing crops so badly. Right. Let's use the previous one. Maybe that would be better. You can see it a bit better here. I don't know what's going on that next one. All right. So any ideas on what could be going on? Just before you do the ECG. So you've got a patient, persistent nausea, vomiting, severe lightheadedness, right, after attending a picnic. So she attended a picnic. She obviously ate something. It wasn't too good. All right. So a bit of maybe early food poisoning or something like that. All right. Anything else that it could be? Generally, you attend picnics outdoors. Could have been a very hot day, a very cold day. You could have hypothermia. You could have a heat stroke. So these are just things that should go through your mind. But it doesn't really tell us much. All right. Okay. Let's see if we can work out what's going on. So what do you guys think about the axis over here? Let's have a look. Let's draw it out. All right. All right. So we have our 4 quadrants. All right. Lead 1 and lead AVF. So which way is lead 1 pointing? Up or down? Upwards. Very good. So that means electricity is moving towards lead 1. Agreed? So it's either there or there. So we either have a normal axis or we've got a left-sided axis, one of the two. We definitely don't have a right or extreme right. Okay. So let's look at lead AVF. Which way is it pointing? Upwards. So that means electricity is moving towards it. All right. So we know it's not this one. So we're just left with the normal axis. All right. Okay. So we're done with the axis. Now let's have a look at the rhythm. Maybe we'll see it a bit better on the next one. I'm just worried just that this top part is cut off, so I'll come back if we need it. All right, so here's our rhythm strip here at the bottom. All right, so what's the first thing that we look at when we discussing rhythm? P waves, isn't it? So the P waves, let's have a look at them. How do they look? They look relatively okay. Occasionally there's a bit of, but is it how, is the way the ECG is connected, a bit of contact, things like that. But overall, they don't look too bad. All right, let's have a look here. So 1, 2, 3, 3.5. So we say between 2 and 4 is normal. So we've got a normal PR interval. Our QRS complexes, are they narrow or wide? So are they narrow or are they wide? Quite narrow, isn't it? Which is normal. Right, you're supposed to have narrow QRS complexes, isn't it? All right. Does the QRS follow every P? It does, isn't it? So the ventricle is always following the atrium, all right? So far everything's okay, and they're relatively regular as well. Okay, relatively regular. So rhythm is actually okay. There's not much of a problem with the rhythm. Let's have a look at the rate. So the rate is 1, 2, 3, 4, 5, 60 beats per minute. We're not too worried about that. She's not bradycardic, she's not tachycardic, nothing like that. And let's look at each zone and try and figure out what's going on. So if you look at the inferior zone, 2, 3, AVF, is there anything that you notice? Let's put it on the bigger one since we're looking at those. 2, 3, AVF. Anything that looks abnormal, doesn't seem right, anything like that? Or does everything look fine? All right, let me ask you a different question. If you were just to see it like that, does it look normal to you, or does it look abnormal? Even if you can't put your finger on it, is something abnormal or is something normal? Okay, what's looking abnormal? Now that's what you got to ask yourself. All right. Do you get what I'm saying? I agree with you, it looks abnormal, but the question is, what's not looking right? So now analyze each piece of that and try and figure out, okay, what's not looking right? And see, I know something's not right here, but what is not looking right? So let's have a look first. So we already know our P waves are relatively okay. We know our PR interval is okay. We know our QRSs are all right. So what else is left? What do we need to look at? What comes after our QRS complex? T waves. Do those T waves look normal? Okay, what looks abnormal about them? Look a bit flat. Very good. Okay. So they just don't look 100%. Agreed. They're quite flat. And normally when you see a T wave, what does it look like? Yeah, it kind of goes up like that. Even if it's a bit smaller, but it kind of goes up. So what's happening to this one? It's like kind of drawn out. It's like flattish. It's taking a long time. So the T wave represents what? It represents the heart contracting. Agreed. Sorry, repolarizing. Sorry, actually going back to normal. Sorry, that's great. Sorry. So that means that the heart is contracting, but then when it's supposed to go back to normal, it's kind of taking its time and it's getting back there. So what could cause that? What do you think? Just thinking about it, even if you don't have an exact answer, what would cause the heart to actually take a long time to actually get back to normal? Sorry? Okay, so a branch block, possibly. And a branch block would be a result of what could cause a branch block? Because a branch block is like a symptom. Branch block is like a cough. You don't admit a patient for cough. You say they've got TB, lower respiratory tract infection. So what can cause bundle branch blocks? Damage. Agreed. And what generally causes damage in the heart? Ischemia. All right. So that's one thing that could be causing it. All right. Is there anything else that helps the heart to contract and expand? Electrolytes. Very good. So could there be a problem with the electrolytes? Very good. And in a patient who's vomiting? Very possible. It could be. So this could be an electrolyte disturbance that you're looking at. All right. So we've looked at the inferior leads. All right. Let's go back. Sorry, just so that we can see this a bit better. So let's look at our septum. All right. So if we look at V1 and V2 here, sorry, it's a bit smaller, but what do we notice again? Because we're expecting still something to be wrong with the T waves. Agreed. So what do we see specifically here in V2? Let's have a look at it on the other side. There's V2. What do we see here? Again, a similar pattern, isn't it? But what's happening with this T wave? It's flat. Yeah, it's flat. It's drawn out. It's look almost the same. Agreed. All right. Let's have a look here. Let's go to V3. Again, we see this long drawn out thing. But can you see this over here? It's flattening out quite a bit, and it even looks like it's got like a double. Can you see that? It looks almost as though it's got a double hump. Agreed. So it's got like one that's going, and then it like kind of goes again. All right. So I wanted you guys just to have a look at that. Then if we look at V5, V6, leads 1, AVL, and if we go back here, even to AVR, I suppose, we just see this prolonged T wave. This T wave is taking a long time. So the question that we have to ask ourselves is, what's causing that? Because it is abnormal. This is not a normal ECG. Something has gone wrong. And you guys have said electrolytes and direct damage to the heart. So how are you going to investigate this patient? What's the first thing that you do to check electrolytes? Yeah, you'll do a blood gas, you'll do a UNE, CMP, all those types of things. All right. And if you suspect it could be ischemia, then you're going to do cardiac enzyme. So it's not difficult. It's just guiding you in what to do. In fact, the majority of the time, if you had a patient with persistent nausea, vomiting, and lightheadedness, would you even do an ECG? You probably wouldn't. All right. Let's be honest about it. We know we wouldn't do it, but you're supposed to. You're supposed to, all right? Because you can see that there's something wrong. There is a cardiac abnormality. But let's assume, or even if you didn't do a 12-lead ECG, let's say you just put it up on the monitors and things like that. And if you were to see something like this, you should be a little bit worried. So even on a 3-lead monitor, if you were to see this long, flat T wave, all right, then you would notice that something is going on. Okay, so at least very good. We picked that up. We know that there's something that went wrong, right? Now let's have a look at the answer to see what's going on. Okay, there's a long answer, so don't stress. The majority of it we don't actually have to know, all right? So we've got a sinus rhythm, rate of 82, right, worked out the wrong way. Prolonged QT interval, and U waves suggestive of hypokalemia, all right? So we're pretty close, all right? We're talking about, but we're gonna get into what is a QT interval and how does it tell you about all of these things, all right? Now, this is just for interest's sake. Sinus rhythm is generally defined as having an atrial rate of 60 to 100 per minute, T-wave axis of plus 15 to plus 25. Sinus beats can be defined by upright, it goes right until the end here, all right? That's nice to know. In the emergency department, generally, we don't worry about atrial axis to a great degree, all right? It doesn't affect us in most cases, simply because atrial abnormalities don't affect your patient to such a great extent as ventricular abnormalities. Doesn't mean you shouldn't know it, but if you don't remember that, please don't stress about it. It's not that important to know in an emergency department setting. If you're working in internal medicine like you guys are, or if you're working in an ICU setting, yes, you need to know about T-wave axis. And when you are like, all right, a bit more senior in an emergency department, then you need to know all of this. But just off the top, don't stress about it, right? The more important thing we're worried about is the QT interval. All right, so what's the QT interval? We're going to get into it, but basically it's the time from the start of your QRS complex, all right, until your T wave, all right? So in other words, the time from the heart contracting to it relaxing, all right? Contraction, relaxing. So it's supposed to happen relatively fast, all right? So basically what's happening to this heart? It's contracting, and then it's, what you call it? Let's have a look and see. Ischemia, very good, Vidisha, thanks. All right, sorry, only saw that now. All right, so what we're saying is that the heart's contracting, but it's taking a long time to get back to normal. And even when it's doing that, it's not doing that with a lot of energy. All right, so you can see here, they talk about hypokalemia, but we'll get into it just now, don't worry. All right, so you guys all know the Bizet formula, I'm guessing. I'm just joking. You know? I'm just kidding. All right, so you don't have to know it, okay? I'm going to teach you guys a bit about it now, but it's not important to know. The Bizet formula actually is something that was used in days gone by when we didn't have machines that worked out all these things. So now your machines give you all the information right at the top. They work out your PR info, they work out the QT, QTC, all of that. Before, we used to just get a strip, and you had to sit and physically do all of it. So we guys had to know these formulas and things like that. And even then, too, we didn't really know them. You kind of eyeballed it and said, okay, it looks like it should be long or short. So don't stress about it, right? But this is the important thing to know. QTC, which is the corrected QT interval, which you'll always see. You always see on the top of your readout, it says QT/QTC is equal to, and then it's got a number over there, 450/330/this/that, all right? So what you are talking about is specifically the QTC, all right? The QTC, corrected QT. So on most of the machines, you'll see it gives you QT/QTC. So the second part is the part that we're worried about. So the numbers are also like 330/310. 450/for this. So you're always looking at the QTC part, right? It's prolonged when it's greater than 450 milliseconds in men and greater than 460 milliseconds in women and children. This is not sexist. I do not know how they work this out. It's not that I don't know. There is some physiological difference, all right? But anyway, just so that you know, those are generally taken as the limits, all right? So 450 and 460, all right? So what are the causes of this prolonged QT? Well, why is it important to know? Because if we look at our ECG, everything else was fine. The only thing that was abnormal was this T wave and the time from contraction to relaxation. That was it. There was nothing else. But look at what can cause it. Hypokalemia, deadly. Hypomagnesemia, yes, quite a problem. Hypocalcemia, also a problem. Ischemia can cause it as well. Elevated intracranial pressure. So all of these things are not minor things. If your patient is hypomagnesemic, that's not a small thing. You know, if your patient is hypocalcemic, it's not a small thing. All right. If your patient's got raised ICP, it's not a small thing, right? Drugs with sodium channel blocking effects, hypothermia, all right? And congenital prolonged QT syndrome. So in other words, congenital prolonged is a diagnosis of exclusion. In other words, you've looked at all the others and there's nothing like that, then you can say, all right, maybe congenital, okay. So patients with a prolonged QTC, especially greater than 500, are at risk of developing torsades, okay. So torsade de Pointes we covered in a previous lecture. If you guys want to go back, you can have a look at it, all right. And the QTC in this ECG is 650 milliseconds. So that means it's quite long. It's quite long. So you guys were right. Something just didn't look right. So in other words, it's just taking a long, an exceptionally long time for the heart to go back to normal, right? The small U waves. Now the question is, what are U waves? So let's look at this. So do you see this little second hump here? All right. Let me just how to highlight it on this. So the U wave P, Q, R, S, T, U. All right. So it looks like a camel's hump. Can you see it that there? It kind of looks like a little camel's hump. That second hump is the U wave. All right. So when you see a U wave, you think of hypocalcemia, hypokalemia. Sorry, I'm saying hypokalemia. All right. So ordinarily, these may be considered non-specific. However, in the presence of a prolonged QTC, they are suggestive of hypokalemia. Even if you cannot remember that, 2 years from now, you're working. I remember attending a lecture where, even if you just remember U wave, query, hypokalemia, that's good enough. Even if you can't remember how it relates to QTC or whatever it is, but at least if you remember, I've got a T wave and it's looking like there's another wave and then my P wave, that U wave is suggestive of hypokalemia. It means I'm going to check what is my patient's potassium. All right. Why is hypokalemia such a problem? What happens to these patients? Arrhythmias, all right, ventricular fibrillation, torsades, like they were saying. So there's a lot that can happen that can actually kill your patient, all right? So in this particular patient, while they were awaiting the studies, the patient developed torsades, but was quickly resuscitated. It was later discovered that the serum potassium level was 2.9, all right, instead of 3.5 to 5.3, and serum magnesium level was also low, all right? And the correction of the electrolyte abnormalities resulted in the normalization of the QTC, okay? So in other words, that was only after they found out. All right. Now let's have a look. So what is the QT interval? We'll come back to this now. So in case you've never figured it, you've never had a proper look, these are how these are all the intervals that are present over there. So let's concentrate on the one that we're looking at today. So QT, right? So we're looking at this initiation of the Q wave until the end of the T wave, all right? This is a U wave. Like I told you, it's a T wave followed by another little wave. All right. So that's the U wave. So this is a nice little thing to keep. If you take a screenshot of it later or something, and keep it just so that you know these are all the little intervals that we're looking at. All right. And then this is the thing that I was telling you guys about. How do you actually work it out? Okay. So before we had to know this. All right. So the QT interval should be measured at either lead 2, V5, V6, several successive beats. You can use large UAs, small UAs. It's nice to read all of this, but at the end of the day, the machine works it out for you. But it's just to show you what they're talking about when they're measuring it. So they're taking from the start of the Q wave to the end of the T wave, basically. All right. So they're measuring from that point to that point. That's how you work out a QT interval. All right. And then you can take a U wave with that as well. But essentially what they are doing, what the machine does is the machine actually does this for you. That's what they were talking about, the Bazet formula, basically is a correction factor based on the rate. Because the faster your heart beats, the shorter your QT should be. And the slower your heart is beating, the longer it should be. It should be. So that means you have to correct. All right. But if you don't know, don't stress, because like I say, the machine works it out for you. All right. So this is the corrected QT interval. So you can see how intricate it can be. All right. That's why I didn't enlarge this, because everybody will just switch off after 2 minutes. Okay. But basically, these are what the different formulas are that you use to work it out. Now, one day when you decide to become a cardiologist, then you need to know this, all right? And you need to know it well. Okay, but for right now, don't stress about it. This is just for interest sake, just to show you guys how intricate these things can be, right? So what about a short QTC, which is less than 350? What can cause it? Hypercalcemia, digoxin, congenital as well, right? We don't see the QTC quite often in our setting unless there's hypercalcemia. Most of our patients are no longer on digoxin now. It's fallen off. All right, but you may still have a couple of your patients that are on it, but more commonly hypercalcemia. But hypercalcemia is something you'd look at more clinically, and then your ECG would come much later on. So it will just support your clinical evidence rather than the other way around. Okay. So again, what are the normal QTC values? Here you can see they talk about 440, and the other one they said 450, but 460 remains constant, all right, in women and children. QTC greater than 500, increased risk of Torsades de Pons, and if it's abnormally short, then you can see what it is, all right. Is the normal QT is less than half of the preceding RR interval. You guys will not remember that. I don't remember that too, so don't stress, all right. So the more important thing again, what are the causes of the prolonged QTC? This is what you need to know. Because there are times this is all you will find on your ECGs, just this QT interval is wrong. And the reason why I brought this out is because I know when most people look at the ECGs, you look at the rate. Some of you may look at the PR interval and then everything else is just, don't worry about that. Let's go further. No, read those things because now you know what to look at and what's there, right? Because these are the causes. So hypokalemia, number one. Hypokalemia and hypomagnesemia often go hand in hand, all right? Very often when we are correcting potassium, we just empirically treat magnesium at the same time, all right? Hypocalcemia, hypothermia, myocardial ischemia, return of spontaneous circulation, which means after resus. Okay, you can have it. Raised intracranial pressure, so that's quite important. Okay, and then congenital, and then medications, but the sodium channel blockers. Okay, all right. So that's just a joke to finish on, right? But it just shows you how it's just important that you must be able to analyze now each section of the ECG, all right? So today's was actually bringing us kind of like to the end of the PQRST segments, all right? I mean, now it was like, it's going to be more like revision of everything over the next few weeks and months and things like that, where we kind of now try and put it in clinical settings, because this was the last part that everybody kind of needed to see, all right, which is the QT intervals. So any questions, anything I want to know, anything that seems a bit strange? The truth is that if you break it down into its little components, and if you understand the ECG's little components, they're actually quite simple on their own. And then you put them all together and it makes one complex thing, all right? But it's a bunch of simple systems working together to create a complex system. It's not a complex system, it's very easy. It's just simply the heart needs to go lugged up, and it needs to be doing that. And if it's not doing that, which part is not doing? That's it. Is it the atrium? Is it the ventricle? Is it the ventricle contracting, relaxing? Is it doing it too fast? Is it doing it too slow? Those are just the questions that you need to ask yourself. And is it an ischemia? Is it not an ischemia? So on and so forth. All right. So don't stress. It's actually not that difficult. I know it seems difficult, but okay. All right. So we'll stop there for today if there's no questions, and then I'll post it to the group so you guys can always check on it later again. And we'll see. All right. Okay.